radiation exposure levels. Specifically asked, probably with the CBCTs, how much are we exposing our patients?
About 15 lateral cephalograms.
It's less than a walk on a beach.
So
if you visited Bangalore,
Goa?
Oh my God, yes, of course.
Then it's lesser,
Goa
much
is like,
lesser.
forget it, because you're on the beach all the time.
Yes,
so,
yes.
I mean, I'm just taking it on a
as
lighter
low as
note.
that, ma'am. So, no harm generally caused with CBCT. If I have to compare it to CT, it's 1/50th or 1/100th of CT.
Much lesser now.
1/100th or even lesser.
And if we are looking at children, we usually go with low dose exposures. We have all of those protocols inbuilt in most of the machines now. Half scans can be done, quarter scans can be done. You can do anything with that, and depends upon what diagnostic need is there. I mean, if you are looking for a fracture, then we need to expose them to a real high. Otherwise, for any supernumerary teeth and all, we can go with very minimal dose and we know exactly where they are. I mean, if you didn't have that, what would you have done? An occlusal radiograph or vertex occlusal radiograph? What do you get out of it? I mean, I have come through a PG course where I have done it day in and day out. And it used to be so difficult to remember that slob rule. Where is it? Palatal? Did the X-ray machine move this way or that way? All these questions are not to be asked and not to be answered. And you can't take risk with a child's health. You can't start buccally and then go palatally. No, you can't do that. So you need to expose the patient to a very minimal dose CBCT that can be achieved these days and go for it. Sir was telling 1/100. I would say 1/200 or 2000. That is the level at which the CBCTs are now exposing. So don't just bother about it.
So for clinicians, a small message. What I would like to say is when you specifically mention about the purpose of scans, the diagnostics can use a specific mode, either high definition or low definition, low dose, and take an image. So it's the responsibility of the clinician is also there in reducing the exposure of the patient.
I think where this question comes is, I think I'm just trying to understand why this question came up. Probably a lot of patients ask nowadays, is there a side effect or something? You know, they have a lot of things now. You write a CBCT, oh, you're writing a CT, so is there a side effect and things like that. To be very frank, if a patient is asking me something like this, I would just ask them, is there a side effect of Lays? Is there a side effect of burger, pizza or not? And they would have no answers and they would just take the prescription for a CBCT.
Some of them might even be smoking and coming and asking us, will this
So the side effect for a thing, and that too, see, we are all dentists of new age now. We don't ask for an investigation unless there is a necessity. And now that we have understanding of this modality for the past 12, 15 years of
in Bangalore.
Literally in our in our own city, I think we have a good understanding. We are not experimenting anymore.
Don't have to worry too much on that. That's what we are saying from our side. Next question to ma'am. Ethical issues, because it's continuation of the same matter. I thought I'd take up this. Ethical issues and practices in CBCT imaging in view of mushrooming CBCT centers across the nation. With so many centers coming up, are there some ethical concerns to be worried about?
Again, very fact is that it's the beginning. See, if you ethics starts when a patient walks into a particular clinic or wherever a doctor sees. So the ethical issue starts there. So you can't say that mushrooming CBCT, no, because it's a demand and supply basis, right? So because there is a demand, the CBCT centers are there. Nobody is trying to have a CBCT machine or a center without seeing the need for the investigation altogether. So I would not say that. Do you put up a question like so many mushrooming diagnostic centers in Bangalore? No, because we are seeing the overall need. People want a next door diagnostic nowadays. Do you want to travel even 2 kilometers in Bangalore today? It is not practical. I just want something next door. I just go walkable distance. So why not have the same positive aspect? Consider it as a positive thing that there's a CBCT next door. So that's what I would.
It's all about having the need and necessity, which has increased the number.
Exactly. Nothing to do with it. See, when as Dr. Vinod has been, he would have seen so many things through his entire journey. When he started out with one center and he's having 50, it would not be, he's not looking at it as just something. We are all backed by all our morals and ethics and everything. And we are seeing a need for it. That's why there are centers.
See, one thing I would like to add here is, even if there is like 10 CBCT centers around my own practice, I mean, I practice right here very near to me, this place. And there are about 5 CBCT centers here. It doesn't mean that I keep referring all my cases. And the other aspect of this is tier 2 cities, tier 3 cities of our state that doesn't have those centers, and things are coming up even there now. And if I say in every, I barely report about 200, 300 cases a month in that range. And among that 300 cases that I report, I will say at least I get about 50 to 60 doctors thanking me that I helped them in saving a tooth. There was a oddly shaped root canal. There was a broken instrument that they had to retrieve. There were so many such cases that I get, and we feel great that at least because the technology is now available, the more the centers come, the prices are going to come down. The patient can afford it more easily. The technology goes right to your clinical place. Now there are a lot of dental clinics in Bangalore who host their own CBCT.
Exactly.
So it's a technology that we see. When IOPA came in, people were afraid of using it because people didn't knew how to use it. Now that we know how to use CBCT, everybody wants to use it, and there's nothing wrong in it.
So basically, number doesn't matter. It's only the ethical usage from the clinician. And just because more number are there, nobody is going to increase it. It's as good
It's
as
absolutely.
that. Okay, coming from ethics, again, a medico-legal implication. What are the medico-legal implications for dentist? Here, I would assume it to be a radiologist. This is a finding on CBCT scan that was not related to the initial reason for imaging. Basically, it's not the primary purpose of scan, but some other important finding was there in the scan. What if a radiologist misses it? Medico-legal implication.
Yeah. This is a very relevant question. Yeah, the doctor has referred for one particular tooth for the scan, but in the scan, the other region is also covered. There is some pathology in that tooth. It is wrong on a part of radiologist if he is not reporting on that, because it's overall well-being of the patient, and especially he has not reported on that, and that has some implication on the patient. Definitely, it is negligence on the part of radiologist, and it becomes an ethical part on even a practitioner. If he sees something, he can put a question to a radiologist to add a note on that. But if radiologist has completely missed out on that, yes, it is negligence. You have to take care to see all the teeth that have been covered in a scan, if there is any pathology, no pathology, and it becomes his primary duty to report to the referring dentist.
So
I want to, sorry to interrupt, but I want to add over here. So I always, when these sort of questions come in, I want to, because we are talking to our own fraternity, I would want to tell them something as a message also. See, we all should be on one side as a team. See, we are working as a team of for you, right? So it's not that we are coming into your clinic as a consultant and doing the case, but we are part of your team when we are sending a report out to you. So if you find something, probably you point it out before it gets into a medical legal issue, because we are all on one side. So it is never, that we are on as another team. So we should work as a team. We should work as a team of dentists in your practice. So it is, we are part of it. Because interestingly, I wanted to bring this particular case to notice. It was a case last year. So how I know a little bit about law is recently my niece is into law, so she keeps talking about it. And medical negligence cases are too many. So she brought up this particular case. Interestingly, it is more in the medical radiology. We don't see much of it in dental radiology, but medical radiology. There was a case where in Tamil Nadu, I think, yes, 2024, last year itself, where some finding was missed out on ultrasonography, and the patient had definitely, they had put up a case and everything. And whatever the claim was, the claim had to be settled by the radiologist, by the doctor who did the surgery, by the nurses, by the hospital, and by the entire team. They had to take up the responsibility wholly and give the whatever compensation to the patient. It was not just the radiologist. So please understand that we are on your team. We are for your, we never take, we were just discussing just before this, we never take calls from a patient. We take calls only from our doctors. We are on your team. So when it is that, why to take it to a point of medical legal? So if you think there's something, be open about it. Tell your radiologist, say that probably this is the case, or probably see we are finding some symptom like this. Maybe you need to check once again. So
So because many times it happens so that without clinical data completely being given, we won't be able to see what is there in radiology. So ultimately, it is none of us are trying to find others' mistakes. In that way, radiologists can find a lot of mistakes of clinician. It's not our job. Our job is to help the patient, clinician, to improve his treatment plan and make it better for the patient. The whole idea is that, hence, no, shouldn't go up to the level of medico-legal points.
So there's a saying, never lie to your lawyer. So please
And
be
the
frank
doctor.
with us.
Yeah.
Please be frank with us so that we can also look into it and present the right perspective to the patient, because these days everybody goes to Google after a report comes to them.
No.
So they will get hell lot of ideas from that, and then they will come and ask you questions. We should be very clear and easy going in what we write in the reports, and it should help a clinician to have a very safe practice in their own way.
Hardly we could take few, and already like more than half an hour has been done. Few questions like this, like how to write a report, CBCT reporting, want to learn CBCT from experts, planning for surgical guide in implant dentistry, please guide us on endo cases. I have a lot of questions like this. One simple, one point I want to mention here is, these are the things which can be taught over a little more longer period of time. So I would like to inform you that Oral Day Academy, in association with the GHA itself, we are starting an academic course on digital dentistry, which is going to be launched in September. The details of the course would be provided by our team by the end of this program, this particular panel discussion. So you can all stay till the end and listen to that. All those who have given these questions, role of CBCT in implantology, full mouth implant planning, how should I analyze CBCT during implant and TMJ? And it takes a lot of time for us to teach. So we have this hands-on course coming up with all the panelists being there as faculty members and few more additional faculty we have, regarding which it will be told in detail by the end of the program. So I'll again take one question, which says regarding standardization. Madam told we all as a team, like we clinicians and everyone, must be a radiologist again. Should CBCT reporting follow a standardized format across nation?
I would love my reports to be standardized and followed across the day.
What if all the radiologists?
So every radio, see, this is the point. See, I find my reports to be the best.
Correct.
Okay, I would not want to say that my pattern is not good. According to everybody over here, see, everybody has this experience, and they know it that you what you're writing is out of experience. So it's following a pattern is just like just putting you in a box. Actually, if you're a little more open about different patterns, you might be able to explore better styles of reporting. Every radiologist has a style of reporting. If you are comfortable with that style,
so we need not confine ourselves to a pattern.
I would not want to, because I would learn something from his reports. We keep learning. We keep learning. If I put him in what I'm writing, probably he may not do his best. So
this is as good as asking all the movie directors to direct the movie in a single pattern. You won't have variety and variants.
Yes, that's the whole thing. But if you want a standard pattern, it is there available on OMR. I think
they are specified.
IOMR has already come up with this.
They
have patterns for everything, and what we should probably stick to with is all that should be mentioned.
That's it. That's it.
In what way I mention is purely to my audience. If I speak in Tamil today in this, most of you would probably not understand. So I have to speak in English or Kannada here to be understandable to most of you. My people who refer to me would love to get the way I give it to them. So it's basically every hotel cannot make the same food.
Right.
True, same way. They have even mentioned about can IOMR implement. Already we got
it. It is already implemented after a lot of deliberations.
Very beautiful deliberations were done, and they have come up with a pretty decent.
They are available on the website.
Well. Anybody can download it.
Yes.
Okay, you can have a look into that. A few direct questions like how to do correct measurement for implant simulation. Measurement and simulation together.
Well, this is one difficulty that most of us who report for implants will come across. There are at least at 100 different angles we can measure a particular slice, and the most clinically relevant slice would be which I think is clinically relevant may not match with what Dr. Vinod thinks or Dr. Jigna thinks or Dr. Utkal thinks, and the angulation at which I took the slice is definitely depicted in our images that we send. but then people miss out on that angulation and then go ahead and try to put the implant at the measurement that I had given at a different angle and encounter the mandibular canal very easily or the sinus very easily. And that is where the ambiguity of answering comes. As far as my knowledge goes, I'm very sure the measurements given on CBCT are 100% correct. 100% correct. The inclination at which I had taken the slice is what you need to understand before you put in your instrument there. So that is what is the issue. And how do you do correct measurements in implant simulation? If you know where to place your implant, then you are doing it right way. If you don't know where to place your implant, then the question comes. So you should learn first how to place an implant, where to place an implant, then the measurement will go accordingly correct.
Or we need to understand
If I like to add here, for this, everyone, whoever is operating or a general dentist, they should have at least a basic knowledge of CBCT. Then everything will fall into place.
Correct.
We don't know anything about CBCT. Yeah, then these doubts will come and also complications.
All we need to remember is that we are talking about 75 microns or 150 micron slice, and the implant is in millimeters. So at different sections, it might look slightly different. There was one more question very similar: why there is discrepancy in root length given by CBCT and actual? Pretty similar answer I have to say.
I am not a big fan of measuring CBCT root canal lengths because root canal is a curvilinear structure, and what slices we give are linear slices. So in one part of the canal would be kinked, and we wouldn't be able to represent that in one single slice. All we do is we give you an indicative. Okay, it should be around this 2 millimeters up or down. That much of difference can exist between the measurement that is given in CBCT to what actually exists in here. And the axis, what we think is right, may not be the way you have created the axis cavity. The reference point where we started off may not be the place where you are going to do the measurement. So these things are very important clinically. If the canal is existing, please use what we call those endomotors and apex locators to
Exactly.
limit your preparations to the place where endodontically ideal preparation should be made.
Even virtual implants. So I keep telling a lot of gatherings where I go and giving a talk. But see, virtual implant plans are only to show it to your patients as a very, very, very indicative gross thing. That's all. Do not
Rely completely.
yes, and rely or even try to ask your radiologist that is this correct? Because see, I'm not an implantologist. So as a clinician, I don't like implantology, to be very frank. I can do a lot of implant planning, but I'm not the one who does it. So I have different concepts about it. Somebody asked me, why have you placed 8 implants in mandible? I'm going to place only 6. I'm like, okay, I would place 1 extra. What if one fails? See, I have a different concept. You have all on 4, all on 6, all on 8, and so many concepts now. So why have those as definitive tools? Just keep it as very, very indicative, educational tools. Do not rely on these plans because after all, everything has to be clinically oriented.
Okay, question. Okay, yeah, we will finish off the questions. We have a lot. I mean, multiple people have asked me as a buyer any specific suggestion for brands. I mean, we're not promoting any specific brand, but I am asking this question to all 3 panelists. They can suggest their favorite brands based on their experience. Each of them have used multiple brand machines.
I wouldn't say we would push for any brand here. Here we have been using all the brands. Most of, all of us have
at least 3 to 4 machines.
No, I have touched everything on earth. I feel whatever is available in India, I have done reporting for all those machines, including the latest ones that are coming. And I would say there's nothing wrong or right in buying a CBCT machine. All you need to look out for is your affordability part. Is the service available there? Does it have a flexibility of using FOV? What is the best resolution that the machine can give you? Because most of the clinical indications are either looking out for a root canal presence or a fracture or an implant. Most often it is implant. For implant, you may not need high resolution imaging and you may not need a whole skull FOV thing. So you have to go by your availability, serviceability, and relying on the dealer who is going to give you that. I buy a machine which was sold for a very less price. The next day morning, the seller is not in town. Whom do I go to and what do I do after that? Look at the ones that are available. If I look at in Jayanagar, there are 4 machines from KST. Then I would also want to put a KST machine in my place because somebody will come and do something there. If there are five plan mega machines here, I would also go with plan mega because at least one is going to be serviced by that person. That's the concept that I go with. Yeah, there are some very bad quality machines, very good quality machines, but that you can make out by looking at it yourself only. We don't have to tell you which is good, which is bad.
Exactly.
Basically, we are not here to endorse any machine. Dr. Joshi, as explained, based on your requirement, whether you want see full skull or if you want to see full mouth, depending on the FOV what you are using and serviceability, that is the biggest thing. As Dr. Joshi told, today they sell the machine, tomorrow they are not there. Where do you go? You have invested so much and you can't go anywhere. So these are the things that can drive what you want to buy.
We'll do one thing, like we'll take one question and one of few answers so that we can take little more, few more questions, because I'm getting a lot of questions on the chat also. I'll try to take it up. Before that, few more. Yeah. As an oromaxillofacial radiologist, can we do practice and give radiological opinion on ENT to ENT surgeons?
It's out of our, it's not in our, we should not do it.
Oh.
I would not touch it because it's not in our, we can't substantiate our report. See, I can report, I can do a reporting, but I can't substantiate it with my degree and my results. I would not touch it.
What we usually did, I mean, this whole gamut of reporting for ENT came during COVID times. And mucormycosis became a very common thing, more so in the central part of India and northern India. Then people came because of loose teeth. And then we got to see, I mean, we insisted that they take a full skull or the biggest FOV that they have on the upper half of the face. And we happened to see a lot of findings. Every finding that we wrote was also mentioned that an opinion and a specialist consultation should be taken to get a final view on this. This is only an indicative. You please go ahead and get a multi-detector CT or a medical CT for this purpose. And if you are talking about the middle year reporting, please don't venture into it. That's not our domain. You can see if you think there is something wrong, just write an indicative that you find that there should be something there. Please get a consultation on that.
A few questions live from chat. I would like to take it up. Yeah, why is reporting so underpaid?
You ask the
I
venture
think this
capitalist.
debate will go on for next 2 hours.
Yeah, easily.
Ask the venture capitalist.
Yeah, interested in course on CBCT online? Yes, we do have an online option also, regarding which the details will be given in the end. I'm planning to establish a CBCT center in my city, which is to Tier. I would like to understand the future prospects of the venture.
It's great. Go ahead.
Yeah. Tier 2 requires, yes, lot of Indian cities do require, because a lot of the CBCT centers are concentrated in Tier 1 cities. Do expose, take the technology to the lower levels so that people can get used to it. CBCT in TMJ, how relevant is it over MRI? That question continues as over MRI.
Well, I mean, for that matter, the standard statement from the Tech City as well as a lot of other College of Radiologists is that imaging doesn't play any role in CBCT. See, it only helps us understanding the pathology that is there. If you need an understanding of the pathology and then want to plan the treatment plan, then please go ahead, get all those things done. But if you have a doubt whether it is TMJ that is causing pain or if it is some other part that is causing pain and it is being called in TMJ as a TMJ disease, then yeah, MRI certainly works. CBCT is great in identifying erosions and the articular disc space, not even disc actually, the space.
Only the space.
Space again, that again needs to be standardized. People don't take CBCTs in centric position and then they ask me to measure the distances, which could be random, and anything that I want I can give them, and there is no standard place where we take measurements. But yes, it may have some role in the near future, but as of now, CBCT as a bony diagnosis, we will only know that there is arthritis there, which most of the patients after 50 will have.
In nutshell, yeah, bony changes, CBCT can help you. Soft tissue changes, very less help is what I can say as far as TMJ is concerned. Then, yeah, one more question from here. CBCT to plan full mouth rehab in a post-cancer patient. Post-cancer patient.
Please go ahead, do it. He has got like zillion times more radiation than our CBCT can do. And it's not going to be any issue when you are exposing the person to CBCT, except pregnant ladies. I would say there is no contraindication to expose patients to CBCT.
Okay. So how to take measurements in zygomatic and pterygoid implants?
So nowadays, because of atrophic maxilla, people are going for zygomatic and pterygoid, and especially pterygoid implants are picking up very well because their long-term studies have been done and they show very good stability. Pterygoid, the deepest point where the lateral pterygoid and medial pterygoid meet, from there to the exit point of around 1.6 and or 1.7 or 2.6 or 2.7, that is where we measure the pterygoid implants. And zygomatic, from the zygoma to the crest of the bone in around 1.6 or 1.5 region. This is where we measure the bone height from zygoma and pterygoid. That is what we can do.
Oh,
I think guided implants are the best. So you have CBCT, go for a guide. That's where you get the best accuracy rather than relying on a simple measurement directly from a CBCT. So, and the newest thing which is coming in with the robotic arm, you can, you have that, you have it already. So you have a CBCT scan, you're doing it with the CBCT scan and you're placing your implant. That's the future. So yes, these are going to be there.
one of the doctor has asked, like,
So utilize the technology when it is there.
Yes, specifically written, want to completely be able to fabricate an implant surgical guide at end. That's what is meant to say. Not just about CBCT. You can utilize other modalities like your 3D printing, which can help you to have a guided surgeries. And in our course, we do cover the part of digital dentistry also. That's what I wanted to say. Then, how do you approach incidental findings on CBCT scan that may not be related to the primary complaint? We have answered that, I think. As part of radiologist responsibility, yes, anything which you feel important has to be mentioned in a report. CBCT versus CT, more enlightenment.
It's more of theoretical question.
Yeah, pure theory. I mean, we put 5 to 10 slides in each of our presentation and end up proving that CBCT is better than CT. That's what you just know
For
that.
dental
think
reasons, yeah.
CBCT is better than.
Simple answer is CBCT is better than CT. Only for cases where you have soft tissue, hard tissue both together, like tumors, pathology, you want to know whether there is fluid inside it or tumor mass inside it, then CT is better.
I think
Otherwise,
a PG student can answer it way better than what we can answer today.
Theory, pure
Yes.
theory. In
They would
clinical
have better-
perspective,
yes.
a lesion or a region which comprises of combination of hard and soft tissue, maybe a CT would be required. In a trauma of middle face, CT would be much better than CBCT. Whereas a mandibular fracture, I would say CBCT would be
Correct.
as simple as that. Some more questions here. How accurate is CBCT volumetric analysis of oropharyngeal spaces? And do it helpful to plan surgery for sleep apnea patients to avoid invasive procedures like endoscopy and CT?
that happens to be my thesis topic. I will take it. I am not letting anybody talk on this. Okay, then yeah, here the question is sleep apnea and radiological studies are a very perplexing thought. When you sleep is when you have a sleep apnea. Gross anatomy of your airway is very beautifully seen on CBCT, so on a CT scan, MD medical CT. But much more grosser anatomy can be seen on a CBCT also. You may miss out on very small lymphoid follicle enlargements and stuff like that. You may not be able to exactly say if there is a real constriction of airway. But yeah, even when the patient is standing, if his soft palate is thick and long and the airway is compromised there, then obviously he would be more prone to obstructive sleep apnea than other normal person. So some giveaway points are there, but yeah, I mean, if you want to just screen a patient for sleep apnea, CBCT is good enough. But if you really want to do a volumetric analysis of that space, I would still not encourage you to do it, which is more right in medical CT. I would still don't want you to do it because that volume is irrelevant. Because the apneic event is going to happen when the patient is in supine position. You know, many of them fall asleep when they are sitting, sleep apnea patient, but they don't have so much of apneic events when they fall asleep in sitting position. But when they fall back and sleep on their backs, that is when the apnea happens, when the constriction of the airway happens. And seriously, that cannot be replicated and seen on any of the diagnostic modalities existing today.
Okay, that answers one more question, which was like sleep apnea and role of CBCT. These are like more like 25 marks question for oral medicine PG.
Screening tool, yes,
Yeah.
100% yes.
A quite relevant question, I feel, for peri-implant assessment, CBCT usage. Is it essential to give a peri-implant measurement in all slices and virtual implant plan? Maybe a radiologist again.
Peri-implantitis is a very interesting thing to study on our CBCTs. To be see, this I could, if you had asked me in the first year of my practice of CBCT reporting, I was like, I myself was trying to find
How to differentiate.
frenetically, like how to differentiate what is it. But now with a lot of scans being analyzed, now I know that there are some factors which show you that it's not artifact and it's a peri-implantitis. So I think peri-implantitis particularly should be analyzed with senior radiologists and then taken a call. If you want to standardize it, it is again probably we need to do a deliberation like this and find some things. There are some factors. Probably we can discuss this when we are doing a course.
So we will make it a point that
to include this.
I mean,
This is something.
a good question which added a content for our course
Yes,
where it's not just the
exactly.
implant planning, post-implant assessment also will be added.
Exactly.
We'll give a demo for that and we will consider teaching it more. CBCT malignancy. One more question, very vague. But
Soft tissue malignancies, no. Hard tissue malignancies, yes, definitely.
so when you're
Sunburst
suspecting a
appearance,
combination
yeah.
or involvement of soft tissue also, better go
Go
for
for CTs.
All of us are
Especially
unanimously
the-
saying this.
The perforation of the cortical plate is not very easily depicted on a cone beam CT. There again, there is a ambiguity there. So please go with CT for such cases. If you know it is a proper malignancy, please don't expose the patient to CBCT and then go for CT.
And it will
And you won't even look at lymph nodes there. You can't see so many other things. Soft tissue spread of an intrabony lesion is also very important that we need to look at. So please go with the medical CT for such cases.
So yeah, can we take CBCT in pregnant women?
No, please don't do that. Don't do that. As far as
medical
possible.
legal implication. Don't do it.
Don't do it.
So all are practically experienced radiologists. They are all clinicians and radiologists, and they are saying no. Even though some of the theory, some of the articles do say that it is safe. We all
It is
know
safe.
that.
You can make the patient wear lead apron, guard the abdomen, everything you can do. But why do you really want to do? I mean, like it's not something that you can't wait for another 3 months or so.
Exactly.
Let the baby come out. Then we have all our time.
We always talk about benefits and risks. When the risk is high, just refrain.
Yeah. So sometimes we will move out of the theory and still take a decision like this because of our experience. This is more important. The pregnancy and the baby is much more important than one particular tooth, which treatment of the tooth can be postponed for a while. Or the treatment can be done without CBCT
Exactly.
for time being.
Without a CBCT.
For that matter, we don't even advise people to take intraoral X-rays as far as possible.
Exactly.
Avoid. I mean, whole concept is ALARA as low as reasonably achievable, and especially in pregnant women, please do follow that.
Technical team can guide us. Like if the time is running out, we have a still long list of questions. As and when the time is up, you can tell us. To explore and expand CBCT, can we do combined practice with ENT surgeons? Question mark. And something like in cases of deviated nasal septum or fractures, they're not getting into the proper ENT, not the middle part. That part was answered. Here it's more like nasal bone.
Why not?
So why not?
We can use it. I mean,
Beautiful possibility of
Yeah.
exploring.
It does happen quite often
Yeah,
that people
nowadays.
mid
trauma
phase
cases.
trauma comes to us and
Mucormycosis, so we explored the frontal sinus.
Exactly.
I mean, we had cases.
sinus, sphenoidal sinus, everywhere we had.
It's as good as a maxillofacial surgeon and a general surgeon or a plastic surgeon
Yeah,
working on the
combining it
same
together.
patient together. So yes, definitely a good combination.
How to look for anomalies in 3D scans? Anomalies.
Okay, we'll pass this for the course.
Oh, okay. How to do immediate implant planning on CBCT? When they say immediate, probably
Same
with the
as,
tooth
yeah.
being present, there's no much difference. It's just that root stump or a grossly decayed tooth is there. You still give the bone measurement and you'll be able.
Sometimes the only thing that you probably have to look for that is that something called as jumping distance. That how much of space, how much of surface contact would the implant make? And simulation implants that are there with us will help us in identifying where all the implant would be engaging, which part of the socket it is going to engage, and how much of the space would be vacant where you need to fill up something, or are you going to allow only the blood clot to allow bone formation, that's your clinical choice. But something that needs to be looked into is the interproximal space between two teeth and the jumping the bone distance that you're going to get there.
Probably last one or two questions I'll end it with. Can CBCT be used for soft tissue assessment and bone density?
Soft tissue assessment, not at all.
Not at all.
Bone density, it is still not an ideal tool to tell what type of bone we have.
Correct.
Because we are not getting ounce-filled units here. It's only pixel numbers what we are getting here. So it's not a right tool, but you can, with experience, you can definitely
Subjectively, we can write about the density, and that's what we all do.
Dr. Vinod will agree with me. The first CBCT machine that he used, the predictability of bone density through that to what he is using today, quite a lot of reliability has come into CBCT, and we don't expect a type 4 D4 kind of density becoming D1.
Correct.
But it used to happen in initial phase, not D4 to D1, at least D3 to D1 used to happen quite often.
Okay. Again, one more question was there, bone density evaluation. That's okay, we have answered that. How to minimize artifact, we have answered. It's done. So give some practical decision-making tips. Question is very vague. All
But
three
it's
of you
nice,
being
actually.
clinicians can give each of your tip with which I will end my questions. This will be the last question taken up. We are almost like 1 hour from the time we started, except that the announcement regarding the course would be done after this and will be given by our panelists. Give some practical decision-making tips.
So to take a CBCT or to report a CBCT?
You say whichever is more important. If you say at what scenario they should take, you give one tip. Sir can tell about a tip where they have written a CBCT and how to utilize it for clinical scenario, something like that. Anything from your.
As a radiologist, I would give a report based only on the radiological findings. I'll never give a report because seeing the clinical scenario, and I would never have seen the patient clinically or his clinical history or even clinical scenario.
Correct.
So I would have given the report only on the findings what I'm seeing in the scan. So it is all up to the dentist to correlate clinically and the history and clinical scenario to arrive at a final diagnosis and treatment. So I'm telling you don't have to take the CBCT report and plan everything. You have to take the clinical scenario, clinical history, and also that particular situation, then only plan your treatment.
So basically, it's radiographic impression with clinical diagnosis is what going to determine the treatment plan for the patient. Very important, and I think key tip what a radiologist can give is don't rely completely on a report and take a decision because you are the masters. You have seen the case in more detail than us. Our volumes don't speak to us. Your patients do speak to you. So in that way, you are in a better position to take a decision about a treatment planning for that particular patient in that scenario. Shall I end with this?
It's a beautiful tip, I think. Yes, and probably from reporting part, somebody who is getting into the reporting, keep your reports such that you don't harm a dentist also. So I'm talking to the students who are getting into the radiology part. I want to give a tip to them. Do not write something which can put
damage anybody.
Yes, because again, as I told, if we are on one side, we are a team. We are a team in that particular clinic. So consider yourself as a part of that team and then do the reporting. Never make a comment which might trouble.
Dr. Signa's tip was for the radiologists, budding radiologists out there, and Dr. Vinod's for the clinicians.
I would probably put that in a nutshell. A radiologist's job is probably like that what Sanjay was doing during Kurukshetra war. Dhritarashtra was blind and pretty far away from there. He very picturesquely described what was happening in Kurukshetra live to him. That is what the role of radiologist is. Clinically, they can't see into the bone or heart tissue. So CBCT does that. And as a Sanjay, you have to truthfully reflect what was happening there. Do not comment of whether it is right or wrong. Only reflect what is happening there. Whether Duryodhana was killed or somebody else was killed, it was not his job. It was only about reporting that part. Do that, and both the ways. As a clinician, I request you, as a radiologist who are other people sitting there, think before you ink. Please do that. Think. When you are sending a patient to a CBCT center, please do describe all the things that are mentioned in our pamphlets. We make very elaborate pamphlets. We only get to see the patient's name, your name, and your signature there. Nothing more. The area of interest is also not mentioned in many places. Please don't do that. That is for the clinicians. For the radiologists, yeah, as both of them have very nicely elaborated, think that it doesn't harm anybody. I mean, in any clinical scenario, there is nothing right and wrong. It is that context which makes it right or wrong. So the person who had broken a file might not have broken it intentionally, or might have done everything that he could do to retrieve that file. But if it still had to be there and if it has survived, might be the right thing that he has done. So please do not make judgmental reports. That is what I would say.
Yes. One small thing, like how we added a story, I would add it that we are packing the parachute bags. Okay, so we just pack it. We don't know anything, whether it would, open up
or not.
or not. So if it opens and if it is landing safely, we have done it this far. We have done maximum number of cases, I would say, that where you have landed safely. So give us the credit for that. And if it has not opened up, you are also at loss because some information was not there from your side as well. So just take it home as that we are.
So new description for radiologists. A mythological character was also introduced today. Sanjaya is being told, which makes very much a lot of sense because his purpose was to describe and give a description of what he's seeing, and we also describe what we see. That is what we do. It was great being a part of this panel with the eminent radiologist with me today. Yeah, it was.
This is the first of its kind, I
Yeah.
think. Where,
Yeah, I mean, we keep seeing CBCT courses and classes happening, 1 hour sessions. I myself have taken many of it. This time when I thought, I mean, how much data or information actually we give? And maybe it's relevant or not, we don't know. Here we took up the questions what were asked by you people, which you felt you have doubt. So we tried clarifying it, rectifying it as much as we could do. This is effort from our side for the first time. Hope it was of some use for you all. With this, we will end our discussion at this point. We will have a small description about the course which is coming up. The details will be given by my technical team. Thank you one and all for your patient hearing for last 1 hour. And thanks to the panel members for their time and their valuable presence here in this panel discussion.
I must say, Friday must have been the most busiest clinical schedules. And if we are seeing more than 200 people here, we should all thank them for having taken time out of their busy schedules and sitting and listening to our answers. Hope we have done some justice to all of you. Thank you.
Thank you. Thank you all.
Uh, Thank you, Doctor. So this was a very engaging discussion. So this is the course we are coming up with. So we have Dr. Utkal as the course director, and we have our faculties who are the panelists for today's session. So we are coming up with this course. So any of you who wants to learn more, ask questions, clarify things, please do join us. And as a special gesture, so for today's webinar attendees, we are having a 10% discount on the course. So the actual course fees, we have two modules, like modes of course. So that is the online mode and the offline mode. So online mode is on demand. So it will be like 12 hours of online session followed by 1 day of hands-on. And we have offline mode for 3 days. And the dates are mentioned in the brochure. It's on the 18th, 19th and 20th of September. So the venue will be here in Bangalore at Jayanagar at Global Healthcare Academy. So the actual fees for the course is 25,000, which is inclusive of taxes. And now for you, for the next 24 hours, you can avail 10% discount on the total fees. You can scan the QR code here, and it is limited to very few seats. So grab yours. If you have any questions, please reach out to us. So we encourage you to take advantage of this opportunity. Any and register at the earliest. So with that, we conclude today's panel discussion. Thank you once again for joining us, and we look forward to welcoming you to our upcoming sessions. So thank you, Doctor. Thank you for the panelists. So it was a very engaging session.